The prison population are more at risk of epilepsy. There's a 3 to 4 times higher incidence of epilepsy within the prison population than within the general population.
Welcome to Epilepsy Sparks Insights, and here we talk with specialist clinicians and researchers to spark improved understandings of the epilepsies worldwide. If you're new here, please do subscribe so you don't miss future conversations, and let's get into today's episode. Today I'm joined by adult epilepsy nurse Karen McLeod, who is here to share why epilepsy is so common in prisons and what can be done to improve care for this overlooked population.
Hi, my name is Karen McLeod. I'm an adult epilepsy nurse. I work in Lincolnshire, covering the Lincoln and Boston localities. I've been an adult epilepsy nurse for around 7 years now, and health inequalities is one of my passions. I'm also an independent nurse prescriber.
And so today we're going to be talking about people in prison who have an epilepsy. They're often quite a sort of forgotten group of people. Could you tell us a bit about that, please?
The prison population are more at risk of epilepsy. There's a 3 to 4 times higher incidence of epilepsy within the prison population than within the background general population. Main reasons are that around 40% of prisoners are known to have traumatic brain injuries in the past. There's an elevated alcohol and drug use, which can trigger epilepsy. There's extra mental health problems. It's estimated around 83% of prisoners will have some degree of mental health problem, which includes personality disorders, anxiety and depression. So there's a lot of reasons why people might have epilepsy in prison. We also have a degree of prisoners who have learning disabilities. It's estimated around 40% of prisoners will have an alcohol problem and around 82% have drug use. And that comes from a study done by Thomason et al. In 2022, where they looked at a category B prison in the UK, housed around 850 prisoners. So their study it's all focused on one prison, but it's relevant because it's a similar size prison and a similar category prison to a lot of the prisons that we see across the UK.
So another problem I understand that we can have, well, actually this is a problem amongst generally the world, but there's access to appointments with epilepsy nurses or neurologists or anybody that they might need to see clinically. Can you tell us about lack of access to care for prisoners, please?
It's estimated that around 38% of prisoners will have seen a healthcare professional regarding their epilepsy within the last 12 months. NICE guidelines say in 2022, which was revised in 2025, that all patients with epilepsy should have an annual epilepsy review with their specialist. If they're having active seizures, then they should be seeing the epilepsy nurse every 6 months. The NICE guidelines in 2016 for the health of prisoners states that epilepsy is classed as a high-risk health condition to have, and that prisoners should have access to their specialist care team. And when they first walk through the doors of the prison, a healthcare assessment's done, their medications is looked at, their healthcare diagnosis is checked over. If any appointments are in place, then they should be honoured. However, we do find that in practice, staffing levels can be a problem if a patient needs to come to hospital and needs to come with 2 prison guards. In my experience, when prisoners have arrived for appointments in a face-to-face capacity, they're handcuffed to a prison guard on each side, which is obviously humiliating for the prisoner, but it's very intimidating for other people in the hospital as well. Seeing somebody in handcuffs and chains being walked through the hospital, it's not pleasant for anybody. Also, when you have a telephone appointment with a prisoner, they generally don't know the appointment's going to be occurring. You never get to speak to the actual patient. You usually get put through from place to place to place until you finally get through to the medical officer, who will give you some information, but as the hospital doesn't have access to the prison records, we can't see for sure what medication they're taking, what the regime is, what the seizure frequencies has been. There's no descriptions of seizures. It's very difficult to manage epilepsy with prisoners, with the prison population. It is documented that there's lack of access to healthcare.
I understand that access to medication can be an issue. Understanding what the patient actually needs and what they're experiencing can be an issue. But I heard a bit of a rumour that actually some of these drugs can be used for things other than seizure control. Is that right?
Yeah, so the drugs that are problematic in the prisons are the pregabalin, the gabapentin, benzodiazepines. Obviously, they have street value within prison. We need to be very careful that those drugs are being given to the patient for their own purposes and it's not being traded and used for other things. So there's a cohort of prisoners who are allowed to give their own medications and hold their own medications, but if they have any of those type of medications, they have to be given to them. And there's about a third of patients who are prisoners have those type of medications. So they're not always given for epilepsy. They may be given for anxiety or nerve pain, for example, but still the same issues. There's also issues around rescue medication. So prisons still use rectal diazepam, which is just, it's just unpleasant for everybody. And there's a statistic around 76% of prisoners don't recall ever having a discussion about rescue medication. So whether that means it never happened or whether they do just not recall the conversation, but it's a large number of people to have forgotten a conversation. It seems likely that they're not being offered rescue medication. It might be that they don't need it, but it's a big percentage to not need it when you've got 4 times the normal population with epilepsy.
Tell us about how appropriate some of the medication they take is. Are they on the right dosage? Do they take it at the right time of day? What happens there?
In my experience, personal experience, I've found that prisoners get the medicines when the medicine round is done. So if it's 12 hours apart, they may get it at 8 a.m. and 4 p.m. and that's that, and there's no way around it. However, the NICE guidelines for prisoners did say that they should be able to get their medication as prescribed, although that's not what I've seen in practice. I have spoke to somebody with lived experience, an ex-prisoner, who said that his experience was that medications were given on time, although the study that I referred to earlier by Thomason et al. Found that around 38% of prisoners don't get the medication at the right time. The prisoners are completely reliant on the prison for their medication. So if they're on something unusual, then if the prison pharmacy can't get it in, then they just don't get it. The prisoners don't have any option to shop around like you would do if you're out in the community. So they're totally reliant. And if they don't get the medicines, then they just don't get the medicines. So they've found that side effects in prisoners are not particularly troublesome, which might suggest that they're not fully optimised on the medication. The Thomason et al. Group looked at the prison cohort that they reviewed, and they found that around 67% of the prisoners could have done with a medication review. So it sounds like they're under threat for epilepsy, and nobody's got an oversight of these people. They move around a lot. The prisons don't tell people that they've moved. Really, what they should be doing is when the prisoner arrives at their front door and they do that first assessment, they should be getting in touch with the local health authority and saying, we have a patient with epilepsy, they'll need some follow-up. Never happens. I've never seen a letter like that ever. I talked to a prisoner with lived experience, and he found that people who had long-term health conditions were well looked after. But in my experience, that's not the case. The prisoners, we don't know who they are. In my current role, I don't see many prisoners at all. And if there's 4 times the amount of people in prison with epilepsy, where are they all? We're not being made aware that they exist. So we can't treat them. It may be that they were under our care in the past, and maybe with chaotic lifestyles, they've DNA'd a couple of appointments and been discharged. But still, when they're in prison, they are entitled to as much health care as somebody who's not in prison. So we should be better at epilepsy care in prisons.
Are there other risks that people affected by epilepsy in prison might be at higher risk of than people outside of prison?
I would say so. I would say that SUDEP's a higher risk in prisons for the reasons that we've already alluded to. There's a lack of rescue treatment. The medications aren't optimised, plus seizures will go unnoticed. Prisoners who are isolated will be having seizures that are not recognised. Even prisoners who are in a cell with another person may not recognise what epilepsy is, or that they're having seizures. So it is really, really hard, and I think that it does increase the risk of SUDEP. We know that young men are at higher risk of SUDEP. We know that people with drug and alcohol, intellectual disabilities are all at risk of SUDEP, high risk of SUDEP, mental health problems. So these patients are really high risk.
I mean, I can say I was put in prison overnight one night because they found me on the floor due to a seizure because I'd been drinking as well, but I'd had a big seizure, a tonic-clonic. They found me unconscious, thought I was just drunk, and put me in a cell overnight. And that's so dangerous. So I can totally see what you're saying. So what do you think then that we need to do to improve things? We've discussed this awfulness, but what can be done, do you think, to reduce the impact on people's quality of life in prison when they have an epilepsy?
I think the onus has got to be on the prison staff. We're not psychic. We can't imagine that a patient's in prison. If we're not told, we don't know they're there. They do move around quite a lot. They'll be out of the local area and it's quite hard to catch up with medical notes from somewhere else. But the NICE guidelines do say that they are supposed to let people know in the local area that a prisoner has come into their area and has a need. And then once we're aware of that, we can pick that up. But in practice, we see very few prisoners.
How can we reach out to these people in the prisons then? How can we implement this?
That's a very good question. They should be following the guidelines. It's probably going to have to come from the health officer, I would think, the medical officer. They'd probably have to be the ones to instigate it, since they would be the ones who are assessing the prisoners' health needs on admission to prison. So they should be the ones who are following the guidelines. So maybe just reaching out to the prisons locally in our locality and asking them to make sure that they're informing us of prisoners who have epilepsy.
Thank you so much, Karen, for sharing your experience and insights on such an important but often overlooked topic. And thank you for watching Epilepsy Sparks Insights. If you found this conversation helpful, please give it a like and subscribe, and hit the bell so that you're notified when new episodes do drop. I'd also love to hear your thoughts or experiences in the comments below too. I do read them. See you next time.